So it is 10 a.m. We will get started as more people slowly join us. Thank you so much for joining us. Bienvenue à toutes et à tous. My name is Sebastian Lebrec. I'm the Deputy Director and Chief Economist of the StrategyCorp Institute of Public Policy and Economy. It's a pleasure to welcome you to this webinar on the future of healthcare in Canada, organized by the Institute. The Institute is the think tank of StrategyCorp on innovation in public policy and economics. We generate original and commissioned policy papers in economic analysis, and we also produce the Intended Consequences podcast. We titled the webinar Protect, Promote, and Restore, a conversation on the future of healthcare in Canada. I'm sure many of you recognize those three keywords: protect, promote, and restore. They come directly from the Canada Health Act, which states that the primary objective of Canadian healthcare policy is to protect, promote, and restore the physical and mental well-being of residents of Canada, and to facilitate reasonable access to health services without financial and other barriers. Coming out of COVID, how can Canada enable its healthcare system to fully achieve this objective is a fundamental question decision makers are grappling with as we speak. Today's webinar aims to contribute to this important conversation by providing ideas and recommendations related to several aspects of healthcare. Our panel of experts have firsthand experience making healthcare decisions in a variety of settings, including government, hospitals, and academia, so I truly cannot wait to hear what they have to say. To moderate the conversation, we have the pleasure of having Carly Weeks join us. Carly is a health reporter at the Globe and Mail. She's been at the Globe for 16 years and has covered many of the questions we'll discuss today. Before I pass the virtual mic over to our moderator, I want to acknowledge the land on which the StrategyCorp Toronto and Ottawa offices are located. Our Toronto office operates on the traditional territory of many First Nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and that this land is now home to many diverse First Nations, Inuit, and Métis peoples. Our Ottawa office, where I'm located, is built on unceded Anishinaabe Algonquin territory. We're grateful for the opportunity to be here and thank the generations of First Nations people who have taken care of and been stewards of protection and care for this land and our environment, and continue to do so today. We recognize and deeply appreciate their historic connection to these lands. As our webinar is being hosted virtually, I do encourage you to do your own research and reflection on where you're located. Miigwech, merci. Thank you again for being here. Carly, over to you.
Thank you so much. It is such a pleasure to be here and to have such an amazing lineup of panelists here to speak about some really important issues related to health. I promised that I would be a friendly moderator today, but plenty of questions to be asked, and I just want to get going as soon as possible because I'm sure we'll be running short of time. Also, we will be taking questions from the audience, so feel free to pop any questions into the Q&A. We're going to be getting to those a little bit later on after I have my chance to ask some questions first. So I'll introduce the panelists who really need no introduction. All of them have had really storied, amazing careers. They've been in the spotlight and are in a prime position to offer some comments on where we are in health and where we're going, how we get to some solutions. So I'll introduce first Dr. Jane Philpott, who among many things has been a family physician in the Greater Toronto Area, a former federal health minister who is now serving as the Dean of the Faculty of Health Sciences and Director of the School of Medicine at Queen's University. Thanks for being here, Jane. And Christine Elliott, who many of us recognize from her very recent days as Ontario Health Minister. During obviously some of the hardest days of the pandemic, Christine recently left on Queen's Park and is now at Council at Fasken. She's also working with Western University in the President's Office on strategies around mental health. And last but not least, we have Philippe Couillard, the former Premier of Quebec, as well as a former health minister as well, who I am pleased to announce, breaking news to everyone here, who is also a senior business advisor with StrategyCorp. So thank you all for being here and for taking the time this morning to talk about some of these important issues. So as I promised, I'd like to jump right in. There's been a number of really important developments in health in the last couple of weeks. The federal provincial territorial agreement is probably among the biggest. And The question I wanted to ask, we have this huge new funding agreement. It was called historic by various members of various governments, but a lot of critics have also pushed back, saying that this is more funding. This isn't necessarily going to get us to the change that's needed. So maybe I'll start with Christine first, someone who was most recently serving in cabinet in health, and just ask your thoughts on what this most recent funding agreement does and how close it will get us to change, maybe what more is needed to get us to the reforms that are needed.
Well, I know that in terms of the amount, it wasn't what many of the premiers were looking for. I think many have called it a good start, but I think that having 4 basic principles and priorities that they have enunciated is a good thing, in the sense that we do need to develop more family-centered care. Primary care needs attention. The workforce, the medical workforce in every respect needs help. Mental health and substance abuse issues have multiplied since the pandemic. And of course, we need to make sure that we have the health information, both in terms of use for patients and specialists, but also for the system as a whole, to be able to measure whether the decisions that are being made are valuable or not, and to be able to plan for future situations. So I think that's all good. However, each of the provinces also, and I'll speak specifically to Ontario, has to have an action plan and a plan to use and collect the information in the way that's most appropriate. So as they say, the devil is in the details, and we'll need to see the action plans and the data plans that Ontario specifically comes forward with, and I imagine the other provinces as well, to understand whether this is actually going to get us to where we need to be.
You mentioned data. So Philip, I'll ask you maybe to jump in there and address that, because I know that was a bit of a sticking point in Quebec, was that, around better data collection and feeding everything into sort of a national database. So, so maybe I'll ask you to touch on that briefly, as well, just speaking about the recent funding agreement and, how it's going to get us to where we need to be.
Okay, well, look, these talks are generally called historic after they finish and they end up, but they rarely live up to that level. It's obvious and it's quite normal. I remember being part of the 2004 conference, which was supposed to fix healthcare for a generation, if we remember well. Looking back at this, it seems to be quite obvious that we put a lot of emphasis on volume production, if I can call it that way, in terms of surgery, wait times, etc., but not a lot on outcomes from the patient's perspective, which I think still should be a significant issue to discuss. You mentioned reporting. It's always the devil lurking in the corner of the room, particularly with Quebec, I have to say, because of the view we have on federalism, which is not always the same as the federal government, even for a federalist government like I was part of. I think the key here is not to get entangled in words and realize that provinces and the federal government have, in general, similar priorities. There are ways to find a transparent and reliable way of reporting data and comparing data. This is critical. And to me, the ideal vehicle for this could be, for example, CAI. So you don't ascribe that responsibility to one government over another one, and you may get past usual problems that we end up on the reporting mechanism. At the end of the day, what we want is people to share priorities, share what they learn, what to do, what not to do, and exchange information. It's always been, I was health minister for a few years. It's always been a disappointment to me, looking at it from a provincial level and the healthcare system, how reluctant sometimes part of the system are to implement successful methods that have been used elsewhere. There's always a good reason not to do it. We're not the same. We're more complicated, less complicated, etc. So that's also should be a significant feature of what we get out of these conferences, apart from money, of course, outcomes, I'll say it again, reliable reporting and shared priorities.
Thank you for that. Jane, I'd love your thoughts as well.
So I would echo what Philippe has said in terms of the fact that every big FPT announcement around healthcare is described as historic, and it is historic in the sense that it will go down in the books and people will look back and see whether it actually did what it was supposed to do. I think one of the good news pieces of this most recent discussion is that the conversation took place at a First Minister's level, which we haven't always seen. It often gets pushed down to health ministers, and obviously all of us loved being health ministers, but we we want these things to be discussed at the level of the first ministers, and I think Canadians want that as well. So we saw that taking place, but I would agree with my colleagues that I don't think there was anything really profound about this, and I see it as a bit of a missed opportunity. And I think if you look at it from the perspective of Canadians as well as frontline health workers, there was a significant amount of disappointment in the discussions. There is no question that our frontline health workers are exhausted. They have gone through 3 very difficult years, and I think they were looking for something truly transformative. At the same time, we're seeing Canadians who see that systems are broken across the country. And of course, I'm always going to speak from the perspective of being a family doctor. And we have never seen the kind of challenges in the primary care workforce that we are seeing right now. A recent study called Our Care, which was a pan-Canadian study survey led out of a group from U of T, has estimated that there are now 6.5 million Canadians who don't have access to a family doctor or a primary care provider. That is terrible. It is actually rippling itself across the entire system. And to hear that the First Ministers hope things will get better is not very encouraging. We all know that hope is not a strategy. We need to see, I think, a much more deliberate, ambitious plans out of both the federal government and the provinces and territories.
Thank you all. Thank you all for that. And I think that leads us really nicely into the next section. You know, we have talked so much in the last couple of years, really decades, but, you know, since the pandemic about what is going wrong. And so now I thought, you know, maybe you are all a bit more at liberty to even say, not being in the positions you are, but, you know, Jane is someone who worked in family health. Philippe is someone who worked in neurosurgery. Like, I'd love to get, and then Christine, you were obviously speaking to a lot of frontline health workers in the last couple of years. So what do our main priorities need to be? And Jane, I'll come back right to you, because, you know, you had talked about family medicine, primary care, and that's something I hear in a lot of the interviews that I do. And I think that that's something that's often missed. You know, because people are seeing crowded emergency rooms and no beds, and so why do we need family care? And anyway, I thought, without leading the witness, you know, what are some of the priorities and how we really start to solve things? Like, if you could make those changes, what would you do?
Are you asking me, Carly?
I'm asking you, Jane, yes.
Okay. Did you give me a magic wand? If I could, I would make sure that every Canadian had access to a primary care home. And that's not necessarily a family doctor. We all know now, and should have known for a very long time, that family doctors alone are not going to fix primary care. They need to function in teams for all sorts of good reasons, because team-based primary care is the mechanism by which you can get the best health outcomes at the lowest cost in a way that's accessible and equitable. And hopefully some of the people who are listening today will know that some of us in primary care have been talking more and more about the fact that if every Canadian child can have access to a public school, then surely every person living in Canada should also be able to have a primary care home. And the benefits of what that would look like in terms of downstream offloading of emergency departments, getting people out of hospital faster, getting illnesses detected sooner, or ideally prevented in the first place, all of that happens in that primary care home. And I think my colleagues who have worked in provincial systems know that anything we can do that will save money is a good thing in the end. So that would be my big wish, is to actually be able to get agreement across the country to say we are going to finally be a country where everyone has access to primary care.
Philippe, as someone who worked in a hospital as well as in politics, similar to Jane, what would be your wish list, you know, casting ahead for priorities of provinces that helps get us to a better place?
Maybe I'll be a bit surprising here, because my stint as the Premier kind of broadened my view on these matters, and seeing at healthcare as part of what governments do for the public. So the first duty of a government and the health minister sitting around the cabinet table is to make sure that social determinants of health are addressed and recognized and acted upon. I would say this is often overlooked. We often dive down too early into technical discussions on how to do this and how to finance that, but this should be kept at the center of our minds. Then, of course, human resources, certification of foreign trained professionals, because obviously immigration is going to be part of the solution. And coming to primary care, I will just echo what Christine said very well. I know it's not, primary care doesn't equate doctor. Other professionals can provide excellent primary care inside the team, nurse practitioners, dietitians, psychologists, social workers, et cetera. So having a primary care home is the right way to go. But we've been saying this for 15, 20, 25 years, and it's very hard to go beyond each profession's little castle here and trying to protect their, let's say, their kingdom within the kingdom, if I can call it that way, what they do in the healthcare system. But until we do this, until we build properly integrated teams as well, population-based, territory-based, it's going to be hard to make change visible. But again, I'm coming back to what I was saying earlier, making sure that the government at the provincial level and of course federally acts upon the social determinants of care and says it, that when I do this, it's not only about healthcare hospitals, it's about health of the population in general.
Right. That's a really interesting point. And of course, that's something that I think has come up and is getting more and more attention, especially during the pandemic, when we've seen how hard hit so many vulnerable groups are. And so, Christine, I'd like you to answer the same question. What do provinces need to focus on to start really changing the system, making it work better, and maybe even touching on how we can do that for some of the most vulnerable people who also tend to be the highest users of healthcare?
Sure. Well, first, let me say I completely agree with my colleagues with respect to the priorities that they've enunciated. But in terms of the social determinants of health and other issues, keeping people well and not always sort of being on our back foot and reacting when people are in crisis, that's what we were trying to do with the creation of Ontario Health and the local Ontario health teams, is to make sure that each person is surrounded by their healthcare system, that they never step out of the system, which sometimes seems to happen. And when you have someone that is being cared for by their local Ontario health team, then you can do things like visiting people in their homes where they can do those sorts of checks to understand if there's food insecurity or if there's housing insecurity and diminish falls risks and all of those other issues that can end people in hospital for reasons that could be prevented. But the other thing that I would say that is a big priority for me is mental health and substance abuse, because I think that's been the biggest repercussion as a result of the pandemic. We knew that many people were in crisis before the pandemic, but that's just multiplied it by 2 or 3 times for everyone, from children to seniors. And I think there's lots more that we need to do to make sure that people can be seen in a more timely fashion. And that's money, but it's also looking at different modalities of care as well.
That's a really interesting point that you raised, and I think the both of you, you're speaking about the social determinants of health. We have obviously this ongoing crisis, housing affordability, the opioid use, and the overdose crisis. So I guess when we speak about those things, and if we put all of that maybe even under the umbrella of mental health, we didn't see a lot in the budget on mental health, and there was a lot of disappointment around that. But we know that there's these huge problems, and it's not just a Canadian thing. It's happening in a lot of different places. But I guess, and I think there's a lot of people out there who are seeing some of the really scary stories in the media, where there's people who are in crisis who have, committed violent acts. I think there's a lot of people who are feeling fearful, and how do we get out of this mess, without necessarily understanding that, people who are struggling with mental illness are more likely to be victims. So, Christine, I thought, as someone who's most recently been there, and, someone who is a champion for mental health, what do we need to do to make this a priority, to kind of, and I think part of the problem is also, even combating some of the stigma and making people care about members of the community that might be, living in a tent in a park. How do we get to a point where we're providing better services and also, bringing those people in from the cold? How do we do that?
Well, I think you're right that there's always been the stigma associated with mental health, and that extends even into some of the medical professionals. And I'm sure my colleagues could speak to that too, where being a psychiatrist isn't necessarily seen as being a medical science. It's something something lesser than that. So we really need to prioritize mental health, have it be seen in the same way as physical health. And that's something that has been done in Ontario with creating the Associate Minister of Mental Health within the health portfolio. But I think that there is much more that can be done. And for example, with Bill 60, that the provincial government just brought forward to deal with backlogs in hips and knees and cataract surgeries and so on, I would certainly recommend looking at how we can boost the number of resources available in mental health as well by looking at facilities that are private, but where people can go and pay with their OHIP card, that it's paid for, those services are paid for by the government. But I think that there's some more openings that we could create to get rid of some of those wait lists, because to me, those wait lists are far more dangerous than wait lists for hips and knees, because people die if they wait too long on a list. And we can't have that in Ontario or anywhere in Canada.
And we've certainly been hearing a lot of terrible stories in recent months, emergency rooms closing down, people waiting too long, children who are waiting months longer than necessary, that they should be for surgeries. Jane, I'd like you to maybe touch on some of those comments that Christine made. We'll talk a little bit about some aspects of private care in a little bit, but, about some of the things that she said, and also, just that whole idea of, people who are struggling with the social determinants of health, with mental illness, not getting the supports that they need, and what you see as some solutions.
Well, again, it's quite fascinating how my colleagues and I have really kind of come together and brought a number of these issues that I very much agree with. And you won't be surprised to hear that I actually think that primary care is the thing that can actually bring those together. And if we could envision, as some of my colleagues here at Queen's and I are doing, establishing these primary care homes in communities that will actually be a place where you will get the mental health care, where you will get social supports. There are a few examples of this across the country, but not nearly enough. One of the reasons I think that we've struggled to get access to primary care, or to mental health care to the extent that it needs to be, is where does it sit? And as my colleagues would agree, it doesn't sit in hospitals. I mean, that's not where people are going to go for the bulk of their mental health care. That's where they go when nothing else is working and it's reached an extreme. But, that primary care team that I talked about earlier, really can involve a number of different people who are really, really good at primary care. And that can be psychologists, it can be social workers. I actually think occupational therapists do some of the best mental health care. And trying to have a place where people can go and get that mental health care. And while they're getting it, recognize that maybe the reason their mental health is so poor is because they don't have a home, they don't have a house, a place to sleep at night. And what they really need to be prescribed is a place to live. As Philippe said, it's about those housing and all of those other social determinants that undergird wellness. But that needs to have a place to sit in communities. And right now, people don't even know where you go to be able to have that kind of access. And if we could envision, and Christine alluded to this a little bit with the Ontario Health Teams, which I think are a brilliant model, not yet fully executed, and we're seeing similar kinds of models across the country. But ideally, that is the place that actually brings together the health and social supports that will be able to undergird people's wellness. And that's where we start to get at the roots of what mental wellness actually requires. But at the moment, the poor family that's struggling with a teenager has mental health supports, doesn't have a family doctor, really is left on their own to try to figure that out. And we need to give people a place to get the care they need.
And our system, when we're writing stories about it, our healthcare system, it's often described as a patchwork. Something's working here, but it's not across the board. If you live in a rural or remote area, you might be out of luck, you're traveling. So I think that there's so many of these issues. Philippe, I'll bring you into the discussion. You had raised the issue of the social determinants of health, and obviously there's a can lead to a cascade of problems through the system, make wait times worse, and everyone's impacted by the social determinants of health, whether sort of they realize it or not. And I guess, part of that question around, making mental health more of a priority, and to Jane's point about creating, care homes where people have sort of an umbrella of support that they can lean on and turn to. I mean, did you see that as the model, or as a model for how to get us to where we need to be, and what is holding back some of those solutions, which have been talked about for a number of years?
In the same way as primary care does not equate with a doctor, mental health does not equate with a psychiatrist. We need psychiatrists, particularly for severe mental disorders. People need to have heavy care, medication, etc. But this is by far not the majority of people that are labeled mental health sufferers in the country. Social workers, as was said, occupational therapists, that's true. These are very helpful people, are very useful too. Now, also, I found out looking at the way psychiatrists work is that most of them have an office-based practice where they load up a significant number of cases that they follow for years, which does not leave a lot of room to see new patients. I think primary care practitioners listening to this certainly can relate to that. Finding an appointment for a new patient with a psychiatrist is quite a difficult task. So here we go again at defining who should do what and what we should be doing together. Now, there's also I would say the political aspect of this that needs to be brought back on the table, is that the CHA, which a good legislation, I think the 5 principles are still very valid, but is it really comprehensive? You could argue with that. Mental health, like home care or elderly care, is kind of the blind angle of the system. And if it's there, it means that most decision makers, of course, they will all say that they could take care of it, they want to improve it, etc. But it's not going to be front and center. So that's also something we should realize. And if one day we look at the CHA again, and not to dismantle it, but to improve it and make it more comprehensive, this is one of the sectors that we need to do. And lastly, when we talk about, now I'll talk about severe mental health issues, psychotic crisis, people in the street, people assaulting their parents. We see this in all big cities, particularly in the country. And who gets to deal with this? The police and the courts. There's also a big problem there. How do we address the crisis situation without immediately taking the person? Yes, he or she needs to be protected against herself, against others, but how do we keep this outside, I would say, the criminal justice system as much as we can, without, of course, putting in question any accountability of what people do, but still, you see where I go. The moment you throw that person in that direction, there's no way back. It actually makes the problem worse.
Mm-hmm. And just to press you on that point a little further, I mean, do you think that, if we had a place where people can go, whether it's like a community clinic, a number to call, like a place where people can go when they're in crisis, I mean, is that really the biggest, it seems like that's the biggest stepping stone toward solving so many of these problems?
Yes, I would say yes, but as usual, it's called crisis centers. They're better managed by people outside the system per se, like community organizations. Why? Because people who are under chronic psychiatric care are they don't like the system too much. They don't want to be around the system too much. They want to stay away from it. So that's an issue that we see each time you go deeper in these situations. Yes, we need crisis centers, but again, not necessarily psychiatrist-centered, community-centered, essentially, with people that people trust. I'm not sure that the chronic sufferer of mental health illness trusts the healthcare system, particularly where the most severe forms of illness are concerned.
I think that's such a fantastic point. And, whether it's looking at mental health or other issues, the lack of trust in the healthcare system and empowering people in the community has, I think, been shown, especially during the pandemic, to be a real winning strategy and formula. Christine, maybe I'll ask this to you, but is that's something that's also worked in Ontario? Sort of giving funding to people who are on the ground in communities, mobile vaccination clinics during COVID, for instance, and that kind of thing. So is this kind of, do we just need to be a little even more creative than we're already being, to start to formalize more of these networks to kind of connect people with those mental health supports, primary care supports? If you're thinking more of a solution and how we can achieve some of these things.
Yes, actually, there is, I think, a pretty creative solution that's going planning and hopefully construction soon in York Region. And that came forward not as something that came forward from the Ministry of Health, but came forward from community services there. The police, the mental health service providers, the community service providers, they've had a plan for this center for many years. And we got it started. I hope to be there for their opening because I think it's a brilliant idea. So it's a place where when somebody's in a mental health crisis, they can either go themselves, or if for some reason they're with police officers, they can choose to go there instead of going to the hospital, which is the default position, and which is where people are rarely given the connections to service organizations that they really need. They're just deemed to be whether they need to be formed or not, and that's about it. But at this center, they can stay overnight. They can stay not as long as they want, but for a period of time until they're settled. They can get connected with the community services there, hopefully to break that in and out of hospital cycle that keeps happening with so many people with mental health challenges. And I think that this is it's a great community-based organization coming from the ground up that could perhaps be a template for other organizations in other communities across Ontario. So I think it's a great idea and one that we should watch closely and repeat it wherever we can, I hope.
That's really great, and it's inspiring to hear a lot of these examples, and there are so many. I mean, we hear about the system being broken and crumbling, but there's examples of, and people in the system working really hard, people working outside the system working really hard. But just to kind of go back to that point, when we do hear about something that's novel, that might work, we don't know about this particular case, but how do we make those things kind of better accessible across the province or across the different provinces? It seems like that's always been a bit of a stumbling block in Canada. Something might work here, but then we don't implement it everywhere. And is it lack of will? Is it lack of funding? Like, how do we better mobilize some of the solutions we have?
Are you asking me?
Yes.
Okay, sorry. Well, I think it always does come to money, but I think what we need to do is be a little bit more open to change and maybe start things on a smaller basis, like pilot projects, that sort of thing. Or if we're creating something like the Mental Health Center in York Region, look at it as something that you could create elsewhere, maybe not in exactly the same way because it's a question of resources, but the concept of it and making sure that people can be served in their community rather than having to go into hospital is, I think, is a brilliant idea, and that we should take those steps. We don't have to commit to 100%. We can see what works and take those elements and use them elsewhere.
Amazing. Thank you for that. And we have about 20 or so minutes left. We've got some questions coming in, so please feel free to keep sending them. We'll get to those very soon. But I thought I would just, briefly touch on the opioid and overdose, the opioid use and overdose crisis before we move on to some other aspects regarding privatization and that place in the system. So Jane, perhaps you can speak briefly. It's such a huge problem. It's been going on, and maybe even getting worse, not better, in the past couple of years, certainly with the pandemic. The opioid crisis has, I think, touched every community. It's touched really everyone, and it seems like we have some solutions. We know things that can work, but we're not always very good at implementing them. Things like safe consumption sites. I'm wondering what some of the solutions you think, or that you've even seen in your experience, we could be leveraging better, or what things we need to be doing differently to address that crisis.
Thanks, Carly. It's a great question, and I do think it is certainly the unspoken public health emergency that has been happening. It predates the COVID pandemic, and it continues beyond the COVID pandemic, and the number of people dying tragically continues to rise across the country. So here is where we really need to have an evidence-based conversation, try to take the politics out of it and actually look at what works. And, my colleagues have already spoken about some of the issues around access to mental health supports, which is absolutely part of addressing the opioid crisis. I also heard Philippe refer to the fact that we can't solve these problems through the criminal justice system. And I think most of us would agree with that. I am thankful that we have more in the way of harm reduction services now across the country. I know that they save lives. I know that access to naloxone saves lives every single day, that people who have access to supervised consumption sites can survive what otherwise might be fatal overdoses. But this is really going to require us to be able to depoliticize the conversation and look to international models, look to places like Switzerland that did an incredible job by offering safe supply so that people who are dependent on substances, if you don't have a place for safe supply, your only option is to go to the street. And in almost every city in the country, if you go to the street, you're going to risk the possibility of buying products that are laced with highly toxic substances like fentanyl and increase the likelihood that you're going to die. But in Switzerland, they have really emphasized safe supply and found ways to say, look, you're dependent upon opioids. We're going to give you safe opioids for a while. And we're going to make sure that we see you on a regular basis, ideally a daily basis. And we're going to address what the drivers are of your substance dependence. And maybe it is housing, maybe it is a mental health concern. And the stories that I heard when I visited Switzerland and saw this work were absolutely phenomenal. People whose lives got back on track. We see similar really creative work having been done in places like Portugal around decriminalization and saying, instead of taking you to the courts to solve what we see as your problem, we're going to instead take you to a healthcare provider and a social worker. We're going to sit down with you and figure out what it is that's driving your substance dependence and see how we can help you. And again, the numbers of overdose deaths in Portugal dropped dramatically, as did drug-related crime, et cetera. So that evidence is available to us. Canada has not figured out how to have this conversation. Politicians are afraid of it. I would say politicians of all parties are afraid of having this conversation, but Canadians need them to have the conversation about what works and to ultimately do what works and help people figure out how we can save lives, because it's abhorrent what we have allowed to happen.
Thank you for that, Jane. And I think that you raise a number of really important points, and that idea of just how, it is a very political issue. And I think it's very, to the public, it's something that they need to be sold on. Some things that are evidence-based, but seem, sort of contrary to common sense, safe supply and things like that. Philippe, I'll ask you, maybe, do you agree with some of those evidence-based strategies? Jane's speaking about what more can be done, and maybe how do we even get past the sort of lack of public appetite, in some instances, to see these things expanded.
Yeah, in a society which is more and more polarized and disjointed, I would say, if I compare it to not the good old days, because there were never really good old days, but different times where we didn't feel that in our society, makes it worse now. I'll do a surprising parallel here. So hang on with me for a couple of minutes. Abortion. Abortion is not a moral issue for me. It's the fact that a woman that has an unregulated, unsupervised, unsafe procedure will probably die from it, or at least have a significant complication. So it's a medical emergency in some way. So you don't put a moral judgment on that. Unfortunately, people still do it today. And we see it, of course, south of the border, but elsewhere too. The same goes with these safe consumption centers. If you make it a judgment that by doing so, the government is actually condoning or proving the use of these hard drugs, then you have a disaster from day one. This is a conversation that cannot end well. I think here, when you lead a government and you do this, you have to be strong and say, look, these people like to talk about science and the data. I think there's ample data that show that this is the safe way, the right way to deal with this. Caveat though, the people who go there, they have to be immediately captured by a program that will free them of their addiction in the longer run. What people don't want to see, and I think we can understand that, they don't want to see these houses being set up close to their homes. And let's face it, people are worried about the impact it will have on their neighborhood, and people just circling in and out of these homes without any program that takes them out of the vicious circle of addiction. So that I think is something we should all understand. It's always surprising to me the degree of political resistance we have on this issue in Canada, and we all have to do our own internal thinking about that. I came to be convinced that it was right to legalize cannabis by just seeing what the situation was, what the evidence was. And I'm quite ready, following what happened in Portugal, as you very well said, to envisage this for other drugs than just cannabis, because I think the war on drugs, so-called, has not been a success. I'll just say it that way, and making it more a war than a war against poverty and again the social issues surrounding that is not going to be successful at all. So that's for me a hope that we can. You say depolitize, it will always be politicized. You know, all the issues in health and elsewhere, always there's politics in it. But what you need is people who say, this is not true. This is not the way we should be thinking about that. There is ample data, etc., etc. But you know, I've learned the hard way that saying the truth is not always well rewarded in politics. So at some point, you have to say, "Oh, this is what I need to do, and this is what needs to happen." And that's what I worry. But it's a sign of a deeper issue of our society, much more again polarized, inward-looking, not thinking, lacking empathy. I think this is a fundamental human characteristic that is slipping away from us, empathy. And this is something that, by the way, should be taught at school. So coming back to addiction, because I went a big circle around addiction here, safe consumption centers are the way to go. Legalizing drugs rather than waging a war on drugs is also the way to go.
Thank you so much, both of you, for that. And Christine, I won't ask you to speak on behalf of all conservatives, but you know that's been an issue. It came up time and again. I covered that in the last couple of years with the expansion of or changes to the way supervised consumption sites operated in Ontario. So just wondering for some of your thoughts and reflections on the use of those in Ontario and elsewhere, expansion of safe supply and other solutions that can help address this crisis.
Well, I am an advocate for safe consumption sites and argued successfully for them in Ontario. And I think that they are saving lives. There's no question about that. But the other part of it, though, that I don't think we're doing really well is you want to hopefully have a place where someone feels safe and you can build up that relationship of trust over time, because it's not going to happen overnight. I think people who have drug problems are among the most downtrodden people of all, and they have zero trust of anything that looks like institutionalized medicine. Nothing. There's no trust there. So you want to build that relationship with them, and you want to be able to try to talk them into trying rehab. The problem is we don't always have rehab beds available. So if you have that magic moment that happens and you don't have a bed available for someone, you've lost them. And so what we really need to do is build a much more connected system in Ontario to help people if they wish to get into help, to start with them, find a bed, find a process for them that's going to be successful for them. And I wish to say it was complete, but it's not. We're still building it in Ontario. So there's still a lot of work to do. Thank you so much for that. While we still have a couple of minutes left, I thought we would touch on the not charged at all discussion about private healthcare and, you know, taking it beyond simply the headlines we read all the time about slipping toward two-tiered health and things like that. I mean, there's a lot of private work going on in our healthcare system right now. And I think that there's, important discussions to be had about what that looks like, what it could or should look like if we're looking to the future. Also, it's interesting that just last week, the Supreme Court dismissed that appeal of the long ongoing case regarding private healthcare in BC. So with that, maybe Christine, I'll start with you just because you were just speaking, but just on some of those issues. And of course, Ontario making, I think you alluded to that bill earlier, some of the changes to put more services in private standalone facilities. That's garnered some, controversies and criticism. But at the same time, there's obviously a need with these huge backlogs. We're never going to get through them if we don't do something differently. So maybe you can just speak a little bit about, what without paying with your OHIP card, without having to, pay for services as an individual, what the role of private healthcare is or should look like to get us to where the system can operate better for everyone. Well, Carly, there is so much public confusion over this particular issue that anytime someone hears about a private healthcare provider, they feel that, okay, I'm going to have to pay for that out of my own pocket. That's not what we're talking about here. We already have a lot of private healthcare providers working within our public healthcare system where people don't pay for services with their credit card. I know I'm sounding like the government now, they pay for it with their OHIP card, but that's the case with most private doctors in private practice. They're entrepreneurs, they're running a business, but they get paid for by the government, labs and other groups as well. And then when we're talking about what's going on with Bill 60 in Ontario, it's looking at other organizations that can do cataract surgeries, hip and knee surgeries that are private providers, but they operate within the public system. So you can get things done faster, but you go to perhaps a private clinic that's been accredited, it's safe, and you use your OHIP card. You don't use your credit card. And we've got thousands of people, over 200,000 people waiting to have hips, knees, cataracts done. Now there's always a waiting list. I'm not going to say this is grown up out of nowhere, out of the pandemic, but there's still thousands of people waiting for these surgeries. Similarly, there are thousands of people waiting for mental health services. So Bill 60 allows quantities of these procedures to be done by private providers, but they get paid by the government to do these providers. And for regular citizens of Ontario, they get their surgery done at no cost. So I don't see any reason why we can't expand that as long as it continues in that way. As opposed to the Canby surgeries, which wanted to run a private system in parallel to the public system where people would pay for their services. That's not what we're talking about. At least that's not what I'm talking about. I'm talking about private operators coming into the public system, but operating within the public system where the government pays for it.
Thank you for that. Jane, your thoughts on the same topic, and what more or any other solutions or changes to private care that can be implemented in a way that still is within the bounds of universal or access for all?
So I think Christine has very wisely made sure that people understand that there's a lot of confusion around this. People are not always talking about the same thing. And it's a bit of a red meat issue that gets tossed out. And then people are actually talking about different things. And so as Christine says, the first point is that for what we define as medically necessary care, people should have access to that care based on their medical need, not based on their ability to pay. So that is one thing that is very clear across the board. Secondly, as Christine has also said, there's already an enormous amount of private delivery of healthcare, but there is a difference between private for-profit and private not-for-profit. Now, again, you can't have a blanket statement because, as Christine pointed out, every family doctor is a private for-profit provider. But we do start to see distinctions in terms of some of these facilities where you might be able to use your OHIP card, but is that still functioning for profit or not for profit? And probably the best example is looking at long-term care facilities, for example, where you do start to see real differences in terms of the quality of care as to whether it's a private for-profit or it's some of these really fabulous private not-for-profit facilities that exist and are run by wonderful not-for-profit NGOs across the country. Then I think the third thing to point out in this discussion, which people get confused about, is that when we talk about medically necessary care, the only things that are actually officially covered under the Canada Health Act are hospitals and doctor-provided care. Now, thankfully, many or most provinces have added on and taken on the responsibility to pay publicly for things beyond doctor care and beyond hospital care, but there's not an obligation to do that. And Philippe pointed this out earlier. We have as people like Andre Picard like to say, we have the least universal healthcare system in the world because we don't actually cover some of the smartest things of all: home care, mental health care, palliative care, primary care. There's not necessarily a guarantee that those things will be able to be provided. So that's where we start to actually get into a conversation about how could we be smarter and actually more universal. And we don't have time to get into it today, but I would argue, I think, as Philippe was kind of hinting at, that maybe we need to look at whether or not it's the Canada Health Act that changes, or should there be another health act that brings some universality to those things that actually are really smart investments in health, and that they should be publicly funded, and we would save money down the road on the most expensive parts of the health system, which are hospitals, doctors, and pharmaceuticals. And that's the part that we often pay for, but they're the most expensive parts of the system.
That's great. And I think we have the topic for our next panel, which is, making our system actually universal, and how do we change legislation to get there. Philippe, we have we're going to move to questions any second now, because there's a ton of them. But just if you could briefly touch on that as well. I know it's like the most loaded topic of all. So feel free to take it away.
Yes, I was hoping to get a couple of minutes to do this. I know that time is flying fast, because one of the most significant moment of my political life, 10 years I spent in politics, was dealing with the Shaoli ruling and legislating on the Shaoli ruling, which has been a very significant moment in Canadian healthcare history, not well understood. I still meet people today who tell me, why did you do this? You opened the doors to private care. No, I regulated what was before totally unregulated. There's a big difference. And it was a big defense, actually, of the universal and public nature of our healthcare system. Now we need to define words. It's always about words. First, the word profit. Well, it's impossible to say there will be no profit in healthcare. The obvious example of GP clinics has been quoted, but drugs are made with profit, instruments are made with profit, buildings are made with profit everywhere. You just need to channel the profit to a socially constructive, a socially positive end. To me, I used to say that the problem of the private sector is not its existence, but the fact that it's not available to all Canadians. If you have all these private MRI clinics around the country, how come in some places it's only if you have your private insurance or you pay out of pocket that you can access them? We need much more of these machines, obviously, and we'll need more in the future. So that to me is a good example. And we don't think about also what private means. When I hear people, very well-intentioned people, that said that even the concept of publicly paying private care is destroying the healthcare system, I don't know who is destroying what, because this is not going to be constructive, it's not going to work, it's not going to be accepted by the public. And I will just end, I know that time is going fast. If you look at the regular Commonwealth Fund surveys of healthcare, to people's surprise, if you look at out-of-pocket payment, Canada is one of the worst performers compared to countries in the same survey who have so-called mixed system, private-public, that pay less out-of-pocket every year than we do. So there's a big issue here. People don't want to see it because they fear that if they start discussing this, they're going to open the floodgates to all kind of US-style medicine, which basically nobody wants in Canada. So let's get through these hang-ups and see the situation as it is and concentrate on what people need. People don't really care if they want their cataract out, where it's going to be done. They want it done fast and well and safely. That's what people want. And other countries are showing us the way to do that.
Thank you so much. That was a really fantastic answer. And I thought, it really sheds a lot of light on this topic and really where we need to get to. We'll move to questions. We have, only a couple of minutes left, so we can have some, brief answers where possible, so we can get to as many as we can. The first question, we sort of touched on this at the very beginning about the collection of data, but really, when we're talking about health and health outcomes and the social determinants of health, how we make sure that we're providing equity of access to all and providing, better outcomes for the most vulnerable people, if we're not, say collecting race-based data, how can we ensure that we're providing quality care, getting the best outcomes possible, and also for if we're not collecting race-based data, and also the second part of that question, how do we ensure quality healthcare for First Nations, Inuit, and Métis people? So I don't know who wants to jump in first and tackle that. Just go for it.
Yeah, maybe I'll have a touch on this. It surprises me that, again, people feel threatened when certain issues are talked about or discussed, and they don't want to discuss it because they don't want to see the answers and they don't want to hear the discussion. Take the race-based issues around, it's part of social determinants, obviously. And it's obviously there. I'm surprised, I say this as a Quebecer in 2023, that people still say that there's no such thing as systemic racism in large modern Occidental Western societies, which is obviously not true. It's quite obvious that there is. It doesn't mean that we are racist in Canada, Quebec, Ontario, anywhere else. We just accept the fact that we live in societies that have been partly built on the foundations of that systemic racism, and we have to accept that. Slavery is the obvious example for that. Again, data, yes. Sometimes you don't want to look at the data because you don't want to see the answer. I used to be an avid reader of House of God. My colleagues, physicians, probably have read that. It's a very informative book. I encourage everyone to have a read of that. And one of the laws of House of God was, if you don't take the temperature, you won't know the fever. Sounds quite obvious and almost stupid, but it's a very deep truth, actually, if you think about it. So if you want to see something, you don't measure it. If you want to see something, if it's important, it has to be measured and comparable. That's the other thing. Among provinces, and Quebec is part of the issue, it's hard to compare numbers from one province to the other because they're not collected the same way, and they're not interpreted the same way, and they're not published the same way. So this is where our ministers of health could start working together. I think they want to do this now, which is good news. So if we want to improve, we have to measure well, and we have to agree on how we measure and how we publish that.
Anyone else want to jump in before we move on? Okay, we'll jump right to the next question. And that's, this is an important point with our aging population. So just, what the importance of access to geriatric care, palliative services, and how we make that as a priority in the future. And, that's something that, we do talk about, but maybe doesn't get the recognition it needs. So, how do we better incorporate care for seniors, frail elderly, and palliative services in the healthcare system? So someone who wants to jump in.
I'll start if you don't mind. I think this is something that we really need to come to grips with because we know the statistical truth that there's going to be many, many more seniors in the coming years, and we haven't really adequately prepared for it. We know that there's over 30,000 people still waiting for a spot at a long-term care home, but it doesn't, with today's technology, it doesn't have to be long-term care. There's many more people that are able to stay at home longer if they have the right home care supports. And that's what we really need to focus on is building more long-term care spaces and building them in the right way so that people can be safe and comfortable there, not build them in an institutional sense, but also have more home care options because that's where people want to be. They have better outcomes there. And for the sake of the system, it's the least expensive alternative. But the most important thing is that's where people want to be. Nobody wants to live in a long-term care home if they don't have to. But also palliative care. I think building some of the homes for the people that are dying to be able to go and live there and have their families with them and to have their last wishes be fulfilled. I went to one home that was in Newmarket where they told me that a woman had grown up on a farm and she wanted to see a horse again because she loved horses and she was familiar with them. So they actually brought a horse to the patio and she was able to go outside and see the horse. So I think that's what we need to do for people to allow them to be comfortable in their last moments, to be with their family, to have the things that are most important to them. And that's easier on the families, I think, later on to know that they had good quality time with their loved one and not have to worry about the medicines and all the other things that they needed to have to actually be able to spend time with them. So that is something that I know the government of Ontario has spent a lot of money on, and they are huge, huge issues in communities where people will do anything for fundraisers and volunteer activities afterwards, very emotionally attached to them.
Thank you so much. And that was such a beautiful example. That's great. Does anyone else want to jump in before we move on?
Maybe briefly, I start with one of my provocative statements. I would just say, follow the money. The way the system is funded encourages institutionalization of seniors compared to other societies in Europe, particularly, who have a much lower rate of institutionalization because the money is not spent the same way. If I can just summarize it briefly, you have independent measurement of your degree of autonomy, and the funding increases to you according to your level of autonomy. And you make the choice with your practitioners, with your surroundings, your community, where you want to get older and even finish your days. And this transforms the choices that people can make. Not that they will make different choices all the time, but at least they have a choice. Right now, the funding structure makes it so that there's no choice. If you reach that level, you're going to be sent to one of these large institutions that we all know and we came to see as they are during the COVID crisis.
Thank you so much for that. We're not going to have time to get to all of the questions, so I apologize for that. But this obviously, we could go on all day with this great panel. I thought that one of the one question that came in that I thought I would ask, because it is one of the biggest issues that we're facing, which is the rise of chronic disease, and sort of how we, paraphrasing the question here, but really how we better handle things like diabetes, obesity, other chronic health conditions that have major significant downstream effects, and how we can do better at managing those so that we can minimize those impacts, help those people get to live better lives. Really makes the system work better for everyone as well. So wondering who wants to jump in.
I would just say it takes us right back to where we started our conversation on prevention, primary care, and social determinants of health. We are not going to solve chronic non-communicable diseases by building more hospitals. They are the place where people go when those chronic diseases get to the point that they are unmanageable. So upstream investments to make sure people have decent housing, adequate nutrition, supports that will allow them to be able to be socially active are the things that will allow prevention of the vast majority of those chronic diseases. And again, as Philippe has said, follow the money. We're spending money in the wrong places. We need to figure out how to move that spending upstream and save money down the road by trying to help detect diabetes as soon as it's there and ideally prevent it. And the same can be said for cardiovascular disease and lung disease and everything else. But unfortunately, we're not as proactive as we ought to be in our health systems, and hopefully that can change in the years to come.
Thank you for that. Anyone else want to jump in?
Maybe a word on chronic diseases. I think you should add cancer to the list, because more and more with the progress of treatment, people live longer lives, good lives, for as long as possible with cancer. So it's becoming, I will not say always a chronic disease, but more so as we go forward, And just lastly on budgets, I'll tell you a little anecdote, which I always remembered when I started as health minister. I had this multi-billion-dollar budget to manage, which frankly I had no idea what to do with, because it's such a huge sum. By which end do you take it? So I had a little project that I saw somewhere, let's say $15 million. So I go back to Quebec City and I talk to my deputy minister and tell him, Roger, come on. I need $15 million for this. You cannot tell me that out of 20, at the time it was 20 plus, now it's more than double that. You cannot carve out $15 million for my project. He said, look, Minister, we have the $15 million. The right question is, where am I going to take it from? Who am I going to remove it from? This is how decisions are made at the end of the day, because you never look at the base of the pyramid. You always start like looking what you can add at the top of it, and you never question the base of the pyramid. So that I think should be a lesson for our successors. Obviously, we did not succeed in addressing all the issues that we discussed right now, but putting these issues, new ways of thinking on the table will help. Until we go to the fundamental level, the root of these issues, they will not change. Even if you pour billions of dollars, hospitals, machines, computers, the issues will remain the same.
That was a fantastic response. Christine, are we good to leave it there? Or did you want to add anything?
Just a quick remark, if I could, Carly, and I think that Cancer Care Ontario was a really good example and something that we looked at when we were looking at mental health and addictions. And now Cancer Care Ontario has been absorbed into Ontario Health, and there's now a Center of Excellence for Mental Health and Addictions in Ontario Health. And I think we should probably have a chronic disease management group there too, to take a look at what are the best practices, how do we prevent some of these things from happening, maybe even starting with diabetes, because we're still seeing a big increase in diabetes in parts of the province, and taking a look at how we can expand those best practices across the province, because we need to take a look at prevention, hopefully find some way to stop some of these diseases too. But I think that that's something that we really need to take into consideration to stop a lot of unnecessary hospitalizations, that we need to stop it before it gets to that point. And as Jane says, be more proactive instead of reactive all the time.
I think that's a fantastic point to leave this on. And, it was really great to host this chat, to have you all here today and talk about some things that, will get better, solutions that are working. So I appreciate this discussion, and it's important to have these conversations. This is the kind of thing that will hopefully help lead to change. These conversations are happening across the country, and I hope that they're a sign of good things to come. So thank you all for your time and participation today, Jane, Philippe, Christine, and as well as everyone who's been watching, for StrategyCorp, for organizing this, for hosting all of us today. Thank you all so much, and hopefully we'll chat again about how well some of these solutions are working.
Thanks for having us.
Thank you. Thank you.
Bye-bye.
Have a good day, everyone.